Hi everybody, this is Dr. Ihab Abdurrahman, Ihab Tarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum. This is the medication safety course reflecting on medication without harm. This session is about medication safety in the transitional zone. Learning outcome, explain patient vulnerability in the transitional zone, recognize different responsibilities and role to mitigate errors in the transitional zone, explore strategies to reduce errors in the transitional zone. Let us start with the story, methotrexate tragedy. Before we go there, I want you to reflect on these two medications, ceftriaxone and methotrexate. How are you familiar with these two medications? When I look at myself, when I was a fresh graduate, I know ceftriaxone, I know the dose, could be 1 gram, could be 2 gram. I know when to use it for pneumonia, for urinary tract infection, for meningitis, and how to adjust the dose. But I was not familiar with methotrexate. Based on this, let us go and see how we can handle this case. Selwa, she has rheumatoid arthritis, taking methotrexate 17.5 milligram, 7 tablets of 2.5. She takes them once a week for the last 3 years. Her rheumatologist was on vacation and she saw the rheumatology fellow covering his clinic. Selwa asked if they can simplify her dose of methotrexate and they can reduce the number of tablets from 7. The fellow suggested that he can make them 4 tablets, so she can take 1 tablet of 10 milligram plus 3 tablets of 2.5. Selwa agreed for that, and the fellow wrote a transcript, and he wrote methotrexate 10 milligram AD. He was intended to write AD as directed, but unfortunately, his handwriting showed that it was OD, which means daily. So the community pharmacist dispense prescription, labeling the bottle as 1 tablet daily. So Selwa was taking 1 tablet of 10 milligram methotrexate, which is 70 milligram per week, compared to her dose, which was 17.5. Selwa, after 7 days, she presented to the hospital with gluteal abscess, admitted to general surgery unit. The resident doctor writing her admission medication, mistakenly he prescribed methotrexate 100 milligram. Fortunately, this was picked by the nurse, and the nurse interviewed Selwa, and she looked at the bottle and she found that the dose is 10 milligram. She called the resident and she solved the issue, and she left him a note to change the dose as 10 milligram per day. Selwa continued taking 10 milligram every day. Day 8 afternoon, they booked her for abscess drainage, which was 1 day after her admission. And the resident checked her lab test, and she found that Selwa has CBC, renal function, 10 days ago, and it was normal. And she notifies the anesthesiologist there is no need for new blood test. So Selwa was taken to surgery. During surgery, she had excessive bleeding, and wound packing helped to control the bleeding. Next day, after taking 9 doses of 10 milligram of methotrexate, excessive ooze was noted by the night nurse at 6 in the morning before she changed her shift. She packed the wound again, and at 7:30, Selwa developed palpitation, and her ECG showed atrial fibrillation. Cardiology was consulted. The cardiology fellow saw her, and she reviewed the lab test 10 days ago, and it was normal. And she asked the nurse if there is anything outstanding, and the nurse notifies the resident everything is fine, just mild ooze from the wound, which is expected. And the fellow prescribed beta blocker and to control her heart rate and prescribe low molecular weight heparin 80 milligram Q12 hours. Second day, Selwa has excessive petechiae and ecchymosis and in her trunk and legs. And also she had massive bleeding from the surgical wound and GI bleeding. She was transferred to the intensive care unit, resuscitated there, intubated. The nurse in the ICU looked at the methotrexate in the reference source and suggested that methotrexate could contribute to her problem by reducing her platelet number. And new tests were done. Her white cell was 800, leukopenia, and she has also thrombocytopenia. Platelet were 44,000 and hemoglobin was 5.5. Cell will receive 10 doses of methotrexate of 10 milligram per day. Four of them outside the hospital, and at this point, Selwa medication has been seen by at least two consultants, two registrar, two resident, a bunch of pharmacists, a bunch of nurses, and no blood test done and no review for the maximum dose of methotrexate was done. Selwa died from massive gastrointestinal hemorrhage, pancytopenia, methotrexate toxicity. حينما لا تحمل المريض بفكرك استعد لحمله بعضلاتك، ويمضي المريض إلى مثواه الأخير، ونمضي نحن نطبب الآخرين من دون أن نتأمل. This story, this tragedy represents that what can happen in the transitional zone. Transitional zone is a high risk area for patient management in general and also for medication safety. Transition of care represent high risk situation. It occurs when patient move from different geographical area, from one hospital to another, from home to hospital, from primary care to secondary care, even in the hospital from one geographical area to another, from emergency room to the floor, from emergency room to the ICU to the operation room, shifting patient from one place to another. This is a transitional zone and it carries risk. Another transition happens when patient is seen by different provider. In the clinic, if patient seen by different providers, this is the transitional zone, and also in the hospital seen by different provider create a risk for the transitional zone. As you can see here, in the primary care, we prescribe, we monitor, we administer, we dispense, and sometimes we transcribe from one note to another. Transcription is also a risk area. Seeing different provider, it creates a transitional zone. When patient goes to hospital, this is a major transitional zone because sometimes we prescribe new medication for the new problem. Sometimes this medication can interfere or interact with the home medication, plus we might omit some of the home medication. So at the time of admission, this is a transition zone. During the patient journey into the hospital is a transitional zone, and the time of discharge is also a transitional zone. As you see here, patient coming in the hospital, admission to hospital from home is better. We get good history about the medication history. We verify from more than one source so that we can get the best possible medication history. We can modify as we go on depending on the clinical condition and monitoring of the patient. So during the process, many changes can happen, and each one represents a risk, and it's a transitional zone. Pre-discharge, we have to communicate with the patient and engage them, and as a discharge, we have to reconcile and address all these medication. Studies have shown that in the community, 14 to 98% of community dweller, old person, and 27 to 57 of those in residential aged care facility had medication discrepancy. At hospital admission, 3 to 97% of adult patients and 22 to 72 of pediatric patients had at least one medication discrepancy at admission. Significant number of patients, they have discrepancy on admission to hospital. Transfer within hospital, 62% of patient has at least one intentional medication discrepancy at transfer between units, and at the time of discharge 25 to 80% of patients had at least one medication discrepancy at discharge. As you see here, transitional zone happen in the community at time of admission, during hospital journey, and at the time of discharge. And this is a high risk situation. We need to reflect on it and we need to address it. Uh, in case of our patient Salwa, is this a preventable death? How can we prevent that? We need to look at whenever you are not familiar with the medication, it's better you consult a reference. Methotrexate, the usual dose 7.5 milligram, and the maximum dose 20 milligram per week. If any nurse or doctor looks at a reference, they should have known that 70 milligram per week is a high and toxic dose. Transition zone happen at time of admission, at time of transfer, at time of discharge, in outpatient visit, and when patient seen by different providers. In Selwa, we have reflected that a lot of doctors, a lot of nurses, pharmacists, all of them have seen this patient in different transitional zone. Managing medication in the transitional zone, successful implementation require leadership support, situation analysis, creation of document, incorporating this document in the process. So it should be a hospital policy and strategy to reduce risk in the transitional zone by having a policy, by creating documents supporting those in the front line, and by working on the human factor to reduce the error and make it difficult for people to make the wrong thing. We need active participation from all providers, doctors, nurses, pharmacists. We need teamwork, we need collaborative learning, and we need to report our mistake and we learn from them. Ensure there are clear policy and procedure in place. Patient current medication list, there should be a policy that at time of admission, every patient has his home medication listed in a form what we call medication reconciliation. It should be done within 24 hours and the list displayed in an appropriate place in the chart. Medication reconciliation can have the medication name, dose, frequency, route, and at the time of admission, the doctor need to address if the patient should take this medication or not, and at the time of discharge, the doctor should address these home medication should continue or not, plus hospital medication should continue or not. Medication should be written well in the chart, including all the item, the dose, the name, the frequency, the route, and signature, and so on. Ensure there is a clear policy and procedure in place. So this is a responsibility of hospital leadership and should be the hospital direction to manage medication in the transitional zone. And family and patient should be engaged, empower your patient to be involved, educate your patient about medication use by knowing the indication of the medication and how they can use them and when to stop them and when to notify their doctor about any abnormality. Provide access to reliable, relevant, and understandable information about this medication. Ask patients to bring all the medication whenever they come to hospital or clinic. Encourage patient and family and caregiver to keep and maintain accurate list of their medication. These medication lists should be updated and reviewed with patient, family, and caregiver. If you can see here, the responsibility of the high leadership to create policy and to create supporting form, and they should monitor and audit the process. So they have to provide the medication reconciliation and they have to orient the frontline provider, doctor and nurses, about this whenever they join the institute. They should assign responsibility, who does the task and who will monitor. And Then at time of admission, we write the medication reconciliation, writing the name, dose, frequency, route, and we place them in the appropriate place in the chart. The admitting doctor should indicate if the medication should continue or not, and then we reconcile because of the patient condition. Sometimes might need to halt some of this medication. Patient with diabetes, when they admitted with hypoglycemia, we might halt his oral hypoglycemic or insulin. Those with sepsis and hypotension, if they are hypertensive, we might have to halt their antihypertensive. Whenever there is new order, we need to put it on the right form, and we have to address and make sure there is no interaction with other order. And this process should be repeated whenever there is a transition from one area to another, or whenever a new provider coming to the patient, he has to review this list. Patient should be engaged, patient and his family. We need to inform them. Patient should be informed, and they should get the appropriate knowledge and to be empowered about using this medication. Informed patient can navigate self-medication and health choice optimally. The patient is the single constant in patient journey. Only the patient know that what medication they are taking in the transitional zone. Patient should be provided with medication list. This is what we call medication passport. This list, they can have it as software or hardware, or they can take a photo and keep it in their phone. Should be accessible to them, and they can show it to their provider. Information about the medication should be given to them, and patient should be counseled whenever there is a change in their medication in admission at the time of discharge. Take-home medication error are common in the transitional zone. Common errors that happen in daily practice are likely to happen in the transitional zone. Medication safety is everybody's responsibility. Let us take admission and discharge as an opportunity to review medication list and to write medication reconciliation form and reconcile this medication and adjust them accordingly. Be careful whenever you transfer patient from one facility or geographical area to another, and when patient is seen by different provider. And thank you.